Hello, welcome back to the Neurocritical Care Society Masterclass Series podcast. This is your host, John Rosenberg. I'm a neurointensivist at Westchester Medical Center in New York. I just want to say before we begin that the views expressed on the NCS podcast are solely those of the host and guests and do not reflect the opinions or official positions of the Neurocritical Care Society. Today I'm joined with one of my favorite people, a very special guest, Dr. Harold Saltoff. So Harold, many of the listeners of the show may not know who you are. You're a pulmonary critical care physician and point of care ultrasound really guru. So why don't you tell us a little bit about yourself, your accolades, your contribution to the field of POCUS, and please don't be modest.
Yeah, John, thanks for inviting me. So as you mentioned, I'm a pulmonary critical care physician. I trained at NYU and stayed there for a long time. And then about 2 years ago, came over to Westchester Medical Center where I'm the ICU director. I actually got to know what we now call POCUS a long time ago, back in Germany, where it wasn't called POCUS, where it was just part of medical and surgical residency training. It was interesting for me then to know when I came over to the US that that was really locked up and in the hands of radiology. And then I was very happy when maybe like a little bit more than 15 years ago or almost 20 years ago, maybe we got our first ultrasound machine in the ICU. And I was excited and took it from there. And it's really developed into my academic interest. I've been very much involved in teaching. I've built several programs at NYU for residents, fellows, attendings, and now I'm kind of repeating the same thing here, building programs at Westchester. I've been involved in teaching nationally for a while with the VA system, and then for quite some time with the American College of Chest Physician. I'm board certified in critical care echo, and I also teach at the chest board review course for the critical care board certification, echo board certification.
Wonderful, wonderful. So, tell us a little bit about, how we use. I want to hear a little about your philosophy of how you use POCUS in the ICU, and we could start maybe with a case, the classic case: someone comes in hypotension and shock, and how you approach that patient, and also how you can expand a little bit how you approach POCUS in the care of your patients.
So, I mean, maybe first up, I think I really wouldn't be approaching a new patient in the ICU without an ultrasound machine, because it's really your eyes where you can really assess a patient quickly and figure out, for example, as you mentioned, a shock patient, what the course of shock is, right? So in my little own shock algorithm, you can really figure out within like 2-3 minutes most of the time what the type of shock is by just looking at the heart, right? So in the neurocritical care unit, I mean, obviously you get a lot of shock cases. You have a lot of like thromboembolism, for example. So you'd have an obstructive shock picture. Most of the time you can diagnose that right at the bedside with an ultrasound probe by just looking at the heart, seeing a dilated right ventricle that is struggling, maybe a McConnell sign. So if you have a case of tamponade, you can determine that immediately by just looking at the heart. Like within 2 minutes, you can detect your pericardial effusion and see a compressed right ventricle. So again, by just looking at the heart within 2 minutes, you can determine the type of shock. If you have cardiogenic shock, again, by just looking at it, the heart, you can determine the type of shock. If you have a normal-looking heart or maybe a hyperdynamic heart, you could have a hypovolemic state, or you could have a reduced afterload, so a distributive shock state. Most of the time, actually, the history and the clinical context will tell you kind of in that scenario what the type of shock is. If you really are in the dark from the history. You could do some quick additional measurements to determine what the cardiac output to differentiate a preload deficient from a afterload problem kind of state. So from a more hypovolemic shock versus a distributive shock, the hypovolemic shock obviously will go along with a low cardiac output. And you can easily determine that with one quick measurement with the echo probe.
Mhm.
So I think in a shock state where you don't have time to call a lot of ancillary services, you don't want to wait for your echo tech or so, really bedside echocardiography. Most of the time, actually, basic POCUS, with some exceptions where you may want to do some measurements and go to like some more advanced critical care echo, you could figure out what's wrong with your patient.
Mm-hmm. Okay. One, we'll get to Doppler. We'll touch on Doppler a little later. I know you love Doppler and how, but one question I often get as an intensivist, we're taking care of a patient, let's say a high-grade subarachnoid hemorrhage. People want to say, oh, what's their volume status? The terms volume status have somewhat fallen out of favor, and I think what we want to really know is, should the patient get more fluids? If you give the patient more fluids, where's it going to go? Is it going to go somewhere and improve cardiac output? It doesn't go somewhere that you don't want it to go. Maybe tell us a little bit about your understanding, your thought process to understanding using POCUS to help understand hemodynamics and fluid tolerance in the ICU.
All right. So, I mean, obviously, that's like a huge kind of question, a huge field, and really is it has a lot of controversy also still. But I mean, the first question obviously is what's your potential indication or benefit to give fluid? And is there really an indication? Obviously, there are lots of guidelines that are also still controversial. Sepsis guidelines in the neurointensive care unit, you may have different indications. The way I break it down in my own head is really into two main categories. Is there potential benefit, which means is there fluid responsiveness, meaning can we optimize cardiac output with fluid? And then the second question, though, and probably even more important, is there fluid tolerance, meaning are we going to do potentially damage with excess fluid administration? So in my own thinking, I often look for fluid tolerance first because against, I think, the thinking of many people, you can still, or your patient can still be fluid responsive and you already can do a lot of harm with additional fluid, meaning patients can be still fluid responsive, but not fluid tolerant. So, and obviously to differentiate these two, ultrasound again is extremely helpful, right? So if we want to talk about fluid responsiveness, there's a huge literature on this. You can do this with a lot of different tools, not necessarily just ultrasound, but obviously ultrasound is now around in most ICUs, including neurocritical care ICUs. And it's quickly available and it's not that difficult to learn. So the gold standard of assessing fluid responsiveness is really to determine cardiac output and then have an intervention that increases volume temporarily, for example, with a leg raise, and then measure cardiac output again and see if it increased by 10 to 15%. And that's really fairly easy to do with an echo probe with some additional training that all critical care fellows, in my opinion, should learn. And certainly in our unit, critical care fellows are learning that. And we've studied that at NYU and compared the skills of critical care fellows with official echo reads there in a quick determination of cardiac output. And after a relatively short training, the critical care fellows were all able to do this at a fairly accurate way. So that goes to determining, fluid responsiveness. But as I said, I think what's probably even more important is to look for potential damage. So for fluid tolerance. And again, ultrasound can be super helpful to look at this very quickly. If you think about fluid tolerance, pulmonary congestion obviously is one of the main dangers. And ultrasound is very sensitive to pick up pulmonary congestion. Looking for B lines in the lateral lung fields in particular will really pick up extravascular lung water very quickly. It's very easy to learn. The only issue with that is that what we look for, so-called B lines, isn't necessarily specific for fluid. So if you look at your lateral lung fields and you see a normal pattern, A lines, right, that's very reassuring that at least some degree of additional fluid is not going to put your patient into pulmonary edema. That's something, I teach even the residents, before you give a liter of fluid, just check the lungs, lateral lung fields. If you see A lines, you're probably not going to put your patient into pulmonary edema with half a liter of fluid. Now, if you see B lines, an abnormal finding, but you have to think about it and you have to realize that it's not specific for fluid, right? So if you have a patient who has viral pneumonia, for example, or a patient who's got ARDS, so you will have diffuse bilateral B lines, and that doesn't necessarily indicate that the patient is fluid overloaded. So in that scenario, you would have to do some additional measurements to estimate left atrial pressure, which again, with an echo probe is not that difficult to do. And all our critical care fellows are learning to do this. So again, with a little bit of additional training, right, with the echo probe, you can estimate left atrial pressure fairly accurately at the bedside. Very useful tool.
And Harold, I'll just summarize what you said. There are a lot of good nuggets of learning. Taking a step back, most fellows and most training now starts with what we call goal-directed echo, which is we look at the heart, lungs, the other organs, and we just take the heart, for example. We can look at the heartbeat and we can look at we can see what the size of the cavity is, how well the left side's moving, the right side's moving, if there's any ventricular dilation, some gross measures of ejection fraction, if there's any effusion. And then the next level is what you teach, advanced critical care echo, where we use Doppler. And that's basically, we use different types of Doppler to measure the speed of blood flow through a channel, be it a mitral valve, be it the tip of the mitral valve, be it the left ventricular outflow tract, which will help us measure cardiac output. And I remember when I first started, you really pushed me to get into Doppler. And it was at first a little confusing, but if you understand Doppler, you can really do a lot of these advanced measurements, which then once you understand the velocity and the size of a chamber, you can then calculate the pressure. And once you know the pressure difference, you can really understand what's going on between the left heart, left ventricle, left atrium, left heart, right heart. Is that a good summary?
Yes, I think that's a good summary. Overall, rather than like talking about, specific questions in general, once you learn some somewhat advanced techniques with Doppler measurements, measuring flow velocities in the heart, so you can understand patient's physiology a lot better, and then individualize really your care and not go into a like one size fits all. Every kind of patient with sepsis gets 30 cc's per kg or so. So you can really, with some additional training, understand, hemodynamics a lot better.
The other point I want to touch on is what's great. We often focus on the heart a lot. It's I think a very interesting organ to see, and there's a lot of measurements. But I think a good attention to the lung ultrasound helps me in my practice. I know you in your practice a lot, because similar to as you said, if someone has complex heart function, systolic heart failure, maybe diastolic heart failure, valvular issues, looking at the lungs in and of itself can help give you a quick measurement if the patient has, in addition to the clinical context, if the patient has pulmonary edema or not. Can tell you if the patient has a pneumothorax, can tell you if the patient has consolidation. So often I tell my fellows just start with the lungs, because even if you're wrong with the heart, the lungs is a good kind of safety check. And if I can import, like, I know you approach sepsis in a certain way, but for us, let's say we approach a high-grade subarachnoid hemorrhage, and if I could put on my Harold Saltoff hat, if I want to understand if I should give this patient continuous fluids or a fluid bolus, you would basically, one thing you can do is start with the lungs, see if there's any, signs of pulmonary edema, see what their oxygen is on the vent, if they're on the vent. And then you could give them a passive leg raise and measure if that changes the cardiac output just with bedside ultrasound. And based on the clinical context of whether or not you can afford the patient to have more pulmonary edema and whether or not the actual cardiac output improves, you may choose whether or not to give this patient more fluids. Is that how you would approach it? Or is there anything else you would do in that scenario?
Yeah, I mean, I think that that was a very good summary, right? And I would add to it that, what has become a very hot topic in the kind of POCUS community now is to talk about right-sided organ congestion, right? And in principle, that's really nothing that new to look for, but people have given it a score, which is called the VEXAS score, right? So that's a score to assess organ congestion on the right side, so mainly kidney congestion, which then will cause kidney failure. So people have looked for a long time at the IVC and hepatic vein flow, which the latter again involves some simple Doppler measurements. And then in the mix gets thrown in flow pattern in the portal vein, which also changes with right-sided congestion, and then technically somewhat a little bit more challenging, but still possible and not difficult to learn is to look at renal vein flow, which I think is the most direct way to detect kidney congestion. So this all will go into the mix of looking for fluid tolerance. If you see very intermittent pulsatile flow in the portal vein and the kidney in the renal vein, you'll probably be somewhat more cautious with additional fluid.
It seems like in the beginning, we're learning how to look at the structures, learning what normal anatomy, abnormal anatomy is. And then it seems like the kind of next step in ultrasound evolution in the last 5 years has really been to take measurements and to take hemodynamic measurements to better guide your interventions and understand what your interventions are doing to the body in total. And that's through Doppler ultrasonography.
Yeah, I mean, the learning is certainly a continuation. There are as you said, very simple things that are very easy to learn that a lot of our residents are like starting to become pretty comfortable with, right? So lung ultrasound, as you mentioned, is extremely helpful in many situations. I call it always the low-hanging fruit, right? Easy to learn, very useful. We have just, talked mostly about pulmonary congestion, which is really easy to detect and very useful. And you could argue to detect pulmonary congestion is more meaningful than to measure left atrial pressure, because some people have chronically elevated left atrial pressure without pulmonary congestion. What really matters to the patient is pulmonary congestion in that setting. And again, that is extremely easy to learn. So lung ultrasound is simple and in the ICU setting can be very useful.
So I want to transition a little bit from talking about how we use ultrasound, to how we train fellows and how we can build a program. There's a lot of interest in the Neurocritical Care Society and in neurocritical care educators of really formalizing ultrasound education for our trainees and making formal milestones. So tell us a little bit about lessons you've learned in building an ultrasound program and training fellows, and we'll take it from there and talk a little bit about different courses and different methodologies one can take if they're interested in learning more about bedside ultrasound.
Right. So, I mean, first up, I mean, as you said, there's a lot of interest, and I think for good reason, and there's a lot of push for it. And I think, it is already standard of care to use in the critical care setting to use ultrasound. So I think we have to train all our fellows, and, doing procedure under ultrasound guidance is already standard of care and required. So how do you educate your fellows? How do you build a program is really depends on a little bit on your kind of local circumstances, because the biggest issue with building a program is really the lack of teachers. If we look at the traditional teaching method, it goes from attending to fellow to residents to students. That is kind of totally broken down because a lot of attendings have not been trained. And that is really the main impediment then to teach the trainees. So my approach that I've learned over the years is really to start with training the trainer. So and identifying, teaching some other interested attendings, if there are none in your department, really start off with finding some colleagues and that are also interested, train them first so that they can kind of help you build a program because you cannot do it by yourself, right? Then as a kind of a structure, what's often being done and what's relatively easy is to start off with, obviously some reading material, online material, and then starting off with a boot camp. And there have been boot camps and courses for many years. I think one of the earliest was really the Essentials in Critical Care Ultrasound course that has been running at the American College for Chest Physicians for I think almost 20 years now. And its curriculum has kind of been used sort of as a blueprint for a lot of different programs. So as a start, it's always relatively easy to design a boot camp kind of modeled on the curriculum of the chest course. The harder part then I learned is really the continuation phase, right? Because really, obviously, you can learn ultrasound in 2 days, and to keep people engaged and have them scan continuously is really the harder task. So, and that requires multiple teachers, regular conferences, bedside rounds. As always, I think, our best teaching is always at the bedside. So if you can integrate rounds with your Chinese and integrate ultrasound teaching into your rounds, I always think that is the best way to really get everybody engaged and teach everybody not just how to do it, but also how to integrate it into your clinical assessment, because that is really the hard part. It's not that difficult to learn basic POCUS, basic cardiac ultrasound, basic lung ultrasound, to detect hydronephrosis or detect intra-abdominal fluid or even detect a DVT. All these are very useful skills that are actually not that difficult to teach. What I think is most difficult to teach is to have people, especially attendings, but also trainees, change their practice to integrate ultrasound into their daily workflow. So it can be a challenge if you're around on a lot of ICU patients to integrate ultrasound examination into these rounds in a timely fashion can be challenging, but this is really, I think, the most important part of teaching it, how to use it in your daily practice, when to use it and how to apply it in a kind of timely fashion. Those are the real challenges, right? And then a key part to the teaching and to the learning, I think, is to encourage learners to establish a image portfolio, right? And that, an image portfolio will obviously force you to practice, scan on a daily basis, and portfolios are also always components of certificates of completion. They will be components of any hospital credentialing process, and they are a big component of the critical care echo boards.
So if I can, thank you, Harold, for sharing. If I can summarize, it's good to start with introductory boot camp to learn the basic scans, the basic organs, how to interrogate the heart, the lungs, kidney, bladder, look for DVTs, abdominal ultrasound. There are various courses offered. Neurocritical Care Society does offer a course actually every year at the annual meeting for trainees and attending. So that's a good start as well. And then the main thing is then once you have that, the continuation, and you can, if you don't scan, if you're not practicing, you're not going to build your skills. So integrate ultrasound on rounds, weekly, monthly ultrasound conferences, and an image portfolio. And just to give a rough idea how to do that, there are certain cloud services that certain hospitals, certain departments pay for that. If you're lucky, you can tag onto that. There's also ways most ultrasound machines have a way to export images. You can export de-identified images and put them on you can put them on your own server, and there are certain websites where you can sono clip share. You can make an image portfolio of de-identified patients, and then that walks around with you. You can show that to people. They can give you feedback, and you can really compare your images then to the formal imaging if that's done as well. Well, Harold, is there anything? Well, actually, why don't we tell me a little bit about certifications that are available to trainees or to enthusiasts?
Yeah, so there's in the critical care arena, there is now a real board certification, a critical care echo board certification, which really has the most weight, and it's also probably the most difficult one to acquire. It's something, though, I encourage all our fellows to aim for. It entails a fairly difficult test. It's like your critical care boards, a multiple choice test, which is usually given in January. It's administered by the National Board of Echocardiography. And then the even harder part for the board certification is the requirement for a portfolio of 150 full echoes of critical care patients. So it's not easy to obtain, but I encourage all our fellows, and I tailor the curriculum for them so that they can really aim for being board certified. This is, as far as I know, the only real board certification. There are certificates of completions for general POCUS, and they are given by the Society for Hospital Medicine and the American College for Chest Physician. If you look at their website, they have the requirements. It's a multi-step process that involves taking 2 bootcamp courses and then also a portfolio, and at the end, some hands-on testing. Fairly involved, but it's not a board certification. It's a certificate of completion that is given out by the Society of Hospital Medicine and Chest. So, but it's still something that a lot of people do, and it has considerable weight, and it is a way to show your institution and other people that you are competent in basic POCUS.
Well, before we conclude, is there anything else you want to leave us with? Any other messages, any other wisdom or thoughts?
Well, I mean, we covered a lot of things. I hope I conveyed my enthusiasm for POCUS, and I think it really has changed the way we practice medicine. And I hope it will continue to catch on, and I hope we will head for a time where this is really an integrated part of training for all people who work in the critical care arena.
Agreed. Same here. Well, thank you so much, Harold, and I'll see you in a bit.
Okay, thank you, John, again. Thanks for inviting me to this.